Hello, everyone. Welcome to this afternoon's session called A Different Approach to Documentation. Today's speakers are Gerry Dickerson and Charles Sargeant, who will introduce themselves in just a moment. Throughout the session, if you have questions, feel free to post them in the chat and they will be answered at some point in the session, likely at the end. And at the end, I will also post the CEU code and state it verbally for those of you who need it. If you have any questions, like I said, post them in the chat. Other than that, Gerry and Charles, the floor is yours.
Thanks very much, Julie. Good afternoon, everybody. My name is Gerry Dickerson. I'm an ATP and a CRTS in New York City. I work for National Seating and Mobility. I've been in the industry for a while, so I think I have a pretty long history of seeing how things work and don't work. I'm also the president of NARTS. I'm a NARTS Simon Margolis Fellow and a RESNA Fellow. I'll allow Charles to introduce himself in just a second, but our first slide will kind of serve as our disclosure. Charles and I both work in the commercial sector. We both work for NSM. We really have nothing to disclose, as this is representative of no product or endorsing anything. It's purely a discussion of an idea that we had about changing the way that documentation occurs and looking at streamlining and making it a more standard procedure to try to avoid some of the constant pitfalls of having to redo things. So with all of that, I'll let Charles introduce himself and then we'll get started.
Yeah, sounds good. And looks like we're already getting a chat that the share did not work. Are you seeing it now?
Now we're in.
All right, fantastic. All right, thank you. Gerry, great intro. So I'm Charles Sargeant, also work with National Seating and Mobility. I'm the Chief Revenue Cycle Officer there. So what does that mean? I help support and lead our teams that work on prior authorization, billing and collections, and our payer relations teams working directly with our payers. And as Gerry stated, we're going to jump in here and maybe talk about something that is a little unique. We don't talk about very often, give some education and detail on the process as it exists today, but maybe more importantly, have some conversation about how the process could be simplified and why.
Can we skip along? There we go. So we'll go over our learning objectives. All of you will be able to identify at least 4 of the reasons for negative determinations regarding seating and mobility requests. You'll be able to understand, identify, and compare the major components of an LMN LOJ that are needed for reviewers to understand our requests. And attendees will further understand at least 5 of the emerging elements regarding documentation for seating and mobility interventions. This is an interactive kind of discussion. This is something that Charles is very passionate about, and I am passionate about Charles's passion from seeing what I see in the field. So please type your questions into the chat. We really want to have some robust discussions about what we're talking about here today.
Yeah, and Gerry, if you see something interesting in there, since I'm presenting, I can't see it right now, so let me know. Okay.
Oh yeah, sure.
All right, moving through. So kind of setting up where we're going to go today starts with what I would call the CRT dilemma. When I started in CRT, and I've been in DME for over 20 years now, but started in CRT about 12 years ago. I remember the first mentor I had like to say to me quite often, our clients don't kind of need a wheelchair, right? So we all know in CRT, we're in an industry that we're taking care of folks that have a significant need to get through their day. But the interesting dilemma to that is, even though it isn't something that someone kind of needs, it's a process that takes longer than what you see in other areas of healthcare, and in many ways is significantly harder than getting services and equipment in other areas of healthcare. So a clear need, but it's been built in a way that makes it very difficult for folks to get what they need to be taken care of. And so as we start to dig into that and look at the process as it exists today and to kind of set up the problem, you think about the provision of CRT, and that's what we're looking at on this screen. And I've titled it Perfect World, right? And we all know we don't live in a perfect world. And this is what the journey looks like in a perfect world, right? a client has a need, they get in to visit their doctor, that moves smoothly to an evaluation. Everything is completed appropriately in the evaluation. Everybody is fully prepared to provide perfect documentation that doesn't need to go back and forth. Everybody at the supplier is ready to take that documentation, immediately put it together, provide it to the payer. The payer is fully prepared and ready to do a thorough and appropriate review of the paperwork and provide a payer determination and send that straight over to the supplier quickly so the supplier can move forward with any additional parts, base, accessories, etc. that need to be purchased. There's no issue with those products coming in. They show up, we're able to assemble and deliver them and finish the process. And so it doesn't seem overly difficult or burdensome when you look at this perfect world scenario. But what we're going to get into is the nuances, not necessarily on the evaluation side or the purchasing side, but into the nuances of paperwork and how that becomes significantly difficult and can drain time and the submission to the payer and deferral process and so on. And the reality is the process is actually much longer than this little blue line that we put out there, right? As that paperwork starts to come in, it may be wrong. Signatures may be missed. There may be coding and items that haven't been appropriately justified. So that paperwork gets kicked back to the therapist, maybe multiple times. You get that paperwork and you then send it over to the physician's office, and maybe they miss a date or they miss a signature or fill something out wrong in that physician's office. That physician may only come in and do paperwork once a week. And so missing something may result in a 2-week or a 3-week process. You go through all that and you're finally able to get the appropriate documentation based on the complexity of the need of the documentation. And you're finally able to send it over to the payer. And now maybe the payer makes a mistake and defers it for additional information that was already in the LMN, but they didn't see it, and that gets kicked back. Or maybe it is missing from the LMN, and now you start the paperwork process again with the therapist and going back and forth and then back into the payer again. And so this little perfect route of the blue line suddenly becomes 6, 7, 8 times as long because we're going back and forth between these pieces. And what we'll establish as we run through this presentation is some of the reasons that it ends up going back and forth. And maybe it doesn't need to be going back and forth. And I'll be interested in feedback on that and your personal experience as we go through the presentation.
This one is mine. This is something I wanted, courtesy of Resna from last year, just to show you that it's not just a United States problem. This was a practitioner in Kenya who did not quite do the infographic that Charles did, but showed the real supply chain issues, which is exactly what Charles talked about in the previous slide. From evaluation to delivery, this practitioner showed the squiggly line of, man, it starts at one end, and by the time it gets to the user, we have this tangled web of nonsense that just causes such delays and can cause people profound issues. So it's not just a United States problem. And if we were able to pull this off appropriately in the United States, I guess you could wonder, could we make this something that could benefit everybody, to make documentation look like something that everybody can look at in a single frame of reference and come up with an appropriate solution instead of all this mishigash that occurs in the middle.
Yeah, and to the point of that, right, Jerry, it goes back to the slide earlier. It's not something that someone kind of needs. So
right.
It's fairly straightforward. It doesn't need to be that complex to provide something to someone that they need. And so, over the next few slides, we're going to talk about what I already set up in kind of the timeline flow, is what I would call the core time thieves. And so the core time thieves, in my opinion, are the paperwork, the associated complexity and length of that paperwork, the submission process, and the determination with the payer, and everything that can go wrong due to that complexity. And we'll also look at what I would consider non-value add steps within the process.
So shadow work. My next couple of slides are intentionally stark. I don't have the beautifully done infographics that Charles used to make his illustrations. But to me, shadow work is one of the things that so completely takes away from actual service provision. So Charles, if you could go to the next slide. In psychology, it's described as a process that allows individuals to explore and change almost any behavior or problem. And I almost want to make it my life's work to figure out how to get clinicians to be willing to change their processes that allow them to continually fight against funding sources over innocuous, stupid, in New York City, we call them missing information requests. Some of them are 12, 13, 14 items long, including, goniometry of the hand. There are just so many stupid things that happen. If we could come to a consensus on how the documentation should look, and that everybody agrees that once it's submitted, that's what you need in order to make a determination, I think we could change the entire course of what we're doing. And Charles, if you go to the next slide, please. No, there's the
This
one.
was your first one.
It's the one that talks about CRT specifically.
This one.
Oh, sorry. Yeah, thank you. Okay.
Mm-hmm.
I'm also looking at the ones I'm responsible for on the bigger screen, so I can read it. Sorry. So in documentation, it comes after the and we have some discussion in the chat box about the use of LOJ, but it's typically done after a billable encounter. We have payer denials, missing information requests, conflicting information. I heard from a friend of ours in Canada that one of the great denials in their province, and I don't quite remember if it was last year or just in last month, was the signing clinician misspelt their last name, which, I mean, that's right. That's pretty, but apparently that was the number one reason for denials. So, but all of this shadow work occurs after hours. The phone calls, it's not billable. You're not collecting, revenue for your institution, but you're also taking up so much more time on. You have 50 touches on every individual encounter. So instead of being able to provide more quality interventions for people down the line, you're spending all of this unrecognized time trying to get the simplest intervention resolved. And I know there's a bunch of my New York friends and colleagues on this call. Years ago, all of us lost a very dear friend suddenly, and I will swear to this day, because we all knew him very closely. He killed himself in doing missing information reports and following up on the nonsense from insurance companies to try to get his consumers what they needed. And it was a shock to us all. We all miss him every day, but I think this is just wearing us all down, constantly redoing what should be should be done once. The answer should be there. We should have everything. They should have everything they need. We should have everything we need, and we don't have to go through this silliness. And that's my 2 cents on shadow work.
Yeah. So a couple years ago, started thinking about what do we need to do to start to approach small changes that can make big differences in our industry. And maybe a little later in the Q&A session, I'll talk a bit more about some things that are happening today that can make it easier and better within the industry and for our clients. But a couple years ago, we received a response from a payer on a question that was sent in an audit that was occurring. And they brought us to some contract language, and the contract language said, we utilize industry standard documentation. And I said, well, what is that? What do you consider industry standard documentation practices, right? And thought maybe I'd get a logical answer, and they'd say, well, CMS, right? We're going to follow Medicare guidelines, but they didn't follow Medicare guidelines. They were picking and choosing which ones they liked and which ones they didn't like. But in the contract language, it said industry standard. So I started thinking about it and asking around, say, do we have an industry standard? We are the industry. Have we approached the government? Have we approached the commercial payers and had the conversation about what we think would appropriately provision for our clients in a timely fashion? So there's this concept today that folks have as a standard, right? And payers, I think, believe that this exists, but there's a reality that there truly isn't a standard. There's some similar things that different payers do in different ways, but the reality is there isn't a standard. So the question becomes, could there be a standard, right? We know with the standard procedure that's simple, things can happen efficiently and quickly for our clients. And so we're going to explore a little bit some of the proof on how a standard truly doesn't exist today based on outcomes, because for some, there's this belief when you might watch the news sometimes or other things, that there's just this belief that it's just the supplier. The supplier is just not great at what they do. They make mistakes, and that's why it doesn't get delivered as fast as it should. But I think what we'll show in the examples coming up in later slides is that the outcomes within one company are dramatically different from payer to payer. And so why? And kind of the answer is that it's the reality of a standard, that it's not standard. And so we're going to start to dig in and look at the example of complex power. And we'll spend a little time talking about what the Medicare guidelines are for standard power, common deferrals, and those different things. But what we'll start with here is to take a look at some real life data, real life information on evaluation to delivery times for one organization by 4 different payers. And so you can see the dramatic swing providing the same exact type of equipment. So you have an example with Medicare for a complex group 3 power chair that the average time can get north of 100 days. And then you go across the spectrum on different payers, seeing payer A, B, and C, moving all the way down with payer C, averaging, and this is a very high volume payer, averaging less than 40 days for a complex chair from the point of evaluation all the way through the entire process and the delivery to the client. So 60 or 70% less time working with the same supplier based on it just being the differences between whether it's Medicare or whether it's payer C in this situation. So let's explore a little bit of the why. And I think in order to start to explore the why, let's take a look at the model that seems to be creating one of the longer timelines for CRT. And so we'll go kind of through the boring piece of taking a look at what are the requirements from a Medicare standpoint to get a complex power chair. So first piece is face-to-face encounter, right? Recently changed to encounter, the word encounter being used a little over a year ago. So it's an in-person visit to the physician for the purpose of requesting a power mobility device. May also include at that time a comprehensive medical examination. Now, as we all know, that can be referred by the physician to an LCMP, right? So OT, PT, etc. There will need to be a specialty evaluation, which is a written report providing a detailed explanation of why a particular power wheelchair base and each specific option or accessory is needed to address the patient's mobility limitation. The specialty exam must be performed by a licensed certified medical professional, such as a PT or OT, or a physician who has specific training and experience in rehabilitation wheelchair evaluations. Also recently, Medicare did take a step in the right direction again, a little over a year or so ago, took a step in the right direction on simplifying the process and moving to one named item for the written order being the standard written order, right? For those that remember and been around, many have been around for a long time. We dealt with the DPD and the 7-element order, right? And you had to have one in hand before you got the next one. And it created a lot of confusion for folks on what's the difference between the DPD element, a 7-element order, what's the timing and all those different things. So Medicare has been working to make some improvements to make it easier, and the standard written order change was one of them. So standard written order for PMD, you require a standard written order prior to delivery for the base item. The standard written order for the base item may only be written after the completion of the face-to-face encounter requirements. The treating practitioner who completes the face-to-face requirements must be the same practitioner who writes the order or prescription for the PMD. The physician must document the description of the base. And this is an interesting piece, right? It was complicated for no reason. It adds no value. We'll talk about non-value add. The physician must document the description of the base, but the supplier may include the description of the options, accessories, and or supplies that are separately billed in addition to the base. This created a situation where 2 standard written orders must be completed and signed by the physician. So could have just been as simple as 1 standard written order, let the supplier go ahead and list the base and all the accessories on 1 form and have it signed 1 time by the physician. But the supplier is not permitted to do it for the base. That has to be completed in its entirety by the physician. And then the supplier can do what used to be known as the detailed product description, essentially, or a second standard written order for signature, which can create that back and forth. 1 signature is missed, or didn't realize there was another signature, and so on. The last couple pieces, and it's more in depth in this, but these are the main components of paperwork and requirements to get a complex chair. So home assessment, all levels of PMD require that an on-site evaluation of the patient's home be performed prior to or at the time of delivery. The person conducting this assessment should verify and document in a written report that the patient's typical environment supports the use of a power mobility device. And then finally, again, something gotten very right by Medicare, ATP in-person appraisal. Suppliers providing certain wheelchairs as described in the power mobility device LCD must employ a RESNA certified ATP, and this person must have direct in-person involvement in the wheelchair selection process. So this boring overview of the paperwork, but important to understand as we start to move to what are some other payers doing and what do we think makes sense for the future. So here again is a look at what do we see from a prior authorization standpoint in deferrals. Now I'll tell you, there's massive swings in the percentage of time that a supplier receives a deferral from the payer, despite the fact that they're working with the same therapists, same funding specialists, same expertise, dramatic swings in the deferral percentages by different payers. Swings could be as low as 10% or less by an efficient payer, and as high as 30%, 1 in 3 that come through getting deferred or initially denied in the prior authorization process. And when you look at the deferral reasons, they're very consistent. So documentation incomplete or missing is almost always number 1, which gets back to what we're talking about. Why does it happen so often? If it was simple and straightforward and gets the client what they need, why would it be missed so often? Whether that's missed by the supplier submitting it or the payer reviewing it. The second piece, and the second most common, docs insufficient to justify, right? So our medical justification on the individual components, and we'll talk a little bit about that as we continue to move on here. Now the next slide, it's not from a prior authorization standpoint, but it's from a claims standpoint. And for CRT, this isn't as much of an issue as it used to be, clearly, since prior authorization requests or requirement has been put in place for power mobility devices. And so now that we're getting prior authorization from Medicare, the payments come through much more smoothly than they used to. And you can see that the blue line here is getting lower over time. And that's because of that good change in implementation by Medicare. But what I wanted to point out in this is we look at DME as a whole and the error rate as a whole, that the blue line that you see is insufficient documentation or error, right? So the next one is medical necessity, like we saw in the deferral piece, which is the small little orange part of the bar. But the point of when we look at this is, how is it possible that there's that many documentation errors? If we put together a good process that isn't overly complex and easy for folks to do to get a client what they need, why dramatically, whether we look at this slide for deferrals, working towards getting a prior authorization, or this slide on Medicare claim issues, why is it so common that there's such issue with documentation? And that's what we're digging into here, and that sets up the why we think this is important to review and talk about and see if we can drive change over time. Some change that we've already seen with standard written order was part of our request, that those things should be combined and not be a 7-element order and a DPD, making it more difficult. So before I show the next one, I was curious if we could get a little bit of chat going as we looked at slide 18, and the second most common deferral was docs insufficient to justify. And so curious, I know we have like Lisa Cordero is in the group out there watching the presentation. What are the areas from an LMN standpoint or a justification standpoint that you see the most struggle with in working with payers? I'm curious if that, how you feel about it and what you see in your environment aligns with what we see in the data, right? What we see in the information is the most common deferred items. So Gerry, you see anybody that has some comments on the ones that they run into the most often?
It's interesting. A lot of this discussion has triggered clinicians working back and forth with each other on some of the ways that they're doing things. And sharing their templates. I don't see, my sense is that they feel some of these templates are working to meet all of their needs. I could be misinterpreting that, but I don't really see, and every market is different. So there may be places where there's just things they're not seeing the kind of denials that we see. So if anybody wanted to put something in there, or Zach, can we open up? I almost think this would be worth risking opening. I could open it up, let people's microphones open, and we'll take the risk to see. It's, everybody out there, we all know each other. We'll try not to step on each other's toes, but just to get some dialogue going.
I think the trickiest part, Gerry, is going to be asking a question, or like sharing it, because people might all speak at once, but that's totally fine if they want to ask it. I can't see everybody because there's too many to see if people are raising their hands, but if you want, if you have something, if you just say say your name in the chat and I'll just call on you, that might be easier, so that it's not like 7 people speaking at once.
Yeah, Gerry, we're okay. We can continue on, but I was just curious if anybody, was passionately having issues out there with their letters of medical necessity, and certain accessories maybe you struggle with more often than others.
Not that we've seen so far. So.
Okay, good. Let's continue on. So here's what we see with the most common justification denials, right? So and quite honestly, for many payers, targeting a much closer look at these individual items, whether it be the base or these more specific accessories that we'll look at. So here's what we see is the most common. And there was a good comment in there that Gerry, that you brought up around templates being shared. The reality is it's not easy to write the medical justification, and there are existing tools, templates, programs out there that are appropriate and help especially newer therapists understand how they should be reviewing justification and what are the requirements to understand whether someone qualifies or not. And we'll talk a little bit about that in a bit. So these are the ones that we see the most common denials related to justification of prior authorization process. So group 3 qualification, right? So from the LCD, beneficiary's mobility limitation is due to a neurological condition, myopathy, or congenital skeletal deformity. So that's common. I think it's also important to remember that just because the LCD is written the way that it's written, it doesn't mean that somebody just automatically qualifies for a group 3 because they have one of these diagnoses. Obviously, you could have a diagnosis and not currently have significant mobility issues yet, or could be arthritis, etc. So there's more than just that piece, but it's a pretty quick denial if you don't have that piece. Lower level equipment is often missed in the LMN. So the beneficiary's mobility limitation can't be sufficiently and safely resolved by the use of an appropriately fitted cane or walker. Beneficiary does not have sufficient upper extremity function to self-propel an optimally configured manual wheelchair in the home to perform MRADLs during a typical day, and so on and so forth. I won't read every word on that one. Attendant control, I won't spend time on that. It's just one that you try to get it. Quite often it isn't justified appropriately. Power tilt and recline and electronic connection, or the E2311 through drive control, are two of the most common things that we see and have created over the last couple years significant frustration within the CRT industry. I was actually surprised we didn't see a couple comments saying, you know, I'm dissatisfied with the amount of time I see deferrals on power tilt and recline combination, or the ability to get an E2311. So power tilt and recline, pretty straightforward when we just think about tilt on its own or recline on its own. So the beneficiary is at high risk for development of a pressure ulcer and is unable to perform a functional weight shift, or utilizes intermittent catheterization for bladder management and is unable to independently transfer from the wheelchair to bed, or the power seating system is needed to manage increased tone or spasticity. So those will justify either one individually. The problem that we're seeing pretty common out there is, why are both needed? Why can't one perform the function on its own? And then finally, the E2311 was an interesting development in the industry, that it came to a point in time that on group 3 multi-power, essentially virtually no manufacturers were manufacturing a group 3 multi-power chair without an E2311. It was on every order form. But the truth is, on an E2311, it is something that needs to be medically justified, right? And so you have to justify, as this states here, that the person cannot safely or functionally work toggles. And so that's what we've seen over the last couple of years, is educating everyone on how to properly justify that piece to get the through drive control. All right, so you may find this interesting because not everybody's aware of what every payer is doing. So when you saw Medicare payer A, B, C, what we see with industry leaders is they keep it simple, right? And really are only requiring these 3 things that you see on the screen. So they are requiring, obviously, a letter of medical necessity. Now there is a payer that doesn't even require an LMN, but they're fully integrated and it's their own therapists and physicians who they trust and train. But in the normal scenario where the physician and therapist don't work for the payer or with the payer, obviously a letter of medical necessity is extremely important. So industry leaders utilize a letter of medical necessity. They do not utilize a face-to-face requirement. It's just straightforward justification that most of the time comes from the therapist. They also have the ATP requirement of direct involvement in the selection of the equipment, and they have the prescription, or standard written order in the words of Medicare, prescription required by the physician. And so they feel that, and it's true, that utilization is maintained appropriately. They don't have to go through extra paperwork in time with proof of face-to-face encounter and all those different things, because they have a letter of medical necessity completed by an appropriate professional, signed off on and concurred by the physician, and then ultimately the prescription for what's being provided. And just that change of those things being required makes that significant difference in how often the paperwork gets wrong or gets moved back and forth multiple times between therapist, physician office, client, supplier, etc. So Gerry, we'll talk a little bit about why we think this change is important.
I don't know. After listening to all this and reading some of the comments, I think we should just probably continue with status quo. I think everything is okay. The comments are fascinating, and we're going to be sure to leave time here to have Julie get a couple of people speaking. But Charles did this slide for me, and everybody can look at this and have some different, perhaps, interventions. But if you look, there's people matter twice, and on the left, I think you could include the entire community in both of them, the PTs, the OTs, the physicians, the providers, like myself, in that people matter. And from a consumer point of view, getting somebody their intervention appropriately and in timely fashion, there's a humanity to that. There's somebody who's broken down and cannot go about their life while they're waiting for a prescription or an approval from an insurance company is cruel, in my opinion, and they matter. A quintessential example, and I'm sure everybody's seen it 100 times, having somebody roll into your clinic with a ROHO that's flat, and then you say, well, I have to get a prescription and we have to get authorization to replace your ROHO. That might take 6 weeks. And then to me, you run into risk cost. What does that cost, not only in real dollars, and we all know what it costs, right? And you can, for somebody who goes in for flap surgery, but what's the cost to that person and their family? What's the suffering that goes behind somebody who needed a freaking cushion for $400 or $500 to solve a monumental problem that could have been done by pulling it off the shelf and putting it under their butt and sending them out the door? Need time. We all need time. We need more time to do the right thing. We need more time to advocate. And part of all of this repetitive requests for more information or denials are to keep you busy from doing things that may help promote your consumers or your profession. Charles is in the management end of NSM, and I am just a road warrior. So you could, and so I run, and of course I'm also at the end where I could also say I'm going to mow the lawn from now on. But access to suppliers, and it's a valid question, is that you can ask yourself or talk among yourselves, because Charles and I can't answer it. But is access to suppliers a problem? Is it a good thing that there are essentially two large national companies, or is it a bad thing? Is it a better thing that there's smaller regional companies? Is it a better thing that there's the mom and pops? We can have that's a whole other segment of discussion that we could have about the benefits of size. There's an inertia to size that has its benefits and has its drawbacks, but that's part of our reason for thinking change. And again, rising healthcare costs. What does it cost when somebody breaks down? What does it cost? What would the cost elimination be if somebody was up and functional and going to work? And I won't mention Miss Minkle on this call in the program that we worked at for 20 years, where we had people who had exactly duplicative power mobility interventions. So when Mrs. Jones's power chair went down, she could use her backup chair, call us, have her primary chair repaired. She could continue to go to work. So what is that doing in minimizing her healthcare costs? What does it do to keep her, even if it's not a work-related environment, perhaps it's school or childcare, or just her general well-being, to keep her healthcare costs down? And again, it all goes back to the same thing. People matter. Everyone matters, but everybody involved in our profession matter, and we have to do something to change the course that we're on.
Yeah, and it matters whether a client who needs the chair or replacement chair is waiting 110 days versus 30 days.
Exactly.
It matters. The provider's time matters, the physician, the therapist, right? That's time that could be better spent serving the patient, spending a little more time with the patient versus doing paperwork that has no additional value add to reduce utilization, and that you hit on, but we're saying again, rising healthcare costs. The reality of the way that the paperwork is built today is if it was changed to what we're proposing, which does not seem like a dramatic change, would reduce the administrative cost between prior authorization and billing and collections by as much as 30%. And I'm not even talking about the impact of the physician's office and the folks in that office and the therapists and so on beyond that. So there's real reason for change, not much reason to keep it.
That's a fantastic point, Charles. Get rid of utilization management and utilization review.
So this is the idea of a new standard. Simple, straightforward, an appropriate letter of medical necessity, medical exam and equipment justification, completed by a qualified physician or therapist, just as it is today, and signed by the physician and therapist. And quite honestly, I think we should be encouraging structured industry standard formats for LMNs. We should encourage technology, software, and improvements to make it easier. I can tell you when I go to the physician, I'm not spending a lot of time writing out lots and lots and lots and lots of words. They have software that they utilize where they put the appropriate real information about taking care of me and specific codes and things they can put in there to get the paperwork done quickly. ATP requirement should stay in place. It's critical within CRT, obviously the prescription. And though you saw with some of the industry leaders that do it faster, they don't require a home assessment, many of them, but from an industry standpoint, we believe that's critical to the care of the person we're serving to make sure that it's an appropriate fit for the home and for their lifestyle. So that's the simple and straightforward approach. Now, we'll have a little more fun with this piece with repairs, because repairs is maybe one of the silliest things in any industry that I've ever been in. So let's take a little bit of a look on what's broken with CRT repairs. So let's talk about some of the differences in time to repair CRT equipment. So some items that truly are repairs might require a face-to-face. Does that make sense for a repair? That somebody went through the dramatic paperwork we just spent 40 minutes on to get qualified for a chair, but now certain items that are considered replacement instead of repair might require a face-to-face with the physician again. You may have to have proof of continuous need within a certain amount of time. For Medicare, proof of continuous need on file within a year of providing the repair prior to the repair. You may need a prescription prior to delivery, along with the face-to-face requirement. You may not have any authorization required at all, like Medicare for the things they consider repairs, or you might have an authorization required. You might only have to get an authorization if it's over $750. Again, they may make a determination on whether they really think it's a repair versus a replacement. I put face-to-face twice because I think it's ridiculous. And maybe an auth over $1,500, right? So it begins maybe over $500. It begins to get complex and silly and hard to keep an understanding of what needs to be done for each payer and when. And now here is a pretty dramatic comparison. When we look at the time from the client calling us until we make the delivery, when a payer requires a prior authorization, on average, it can take over 40 days to provide a repair to someone that needs that, right? A backup chair for most payers is not a benefit. This person could be in their bed versus no PAR requirement at less than 10 days. So it's a dramatic difference with just that one thing that a payer has decided to do. Now, what I'll say about this is this should be one of the easier battles for us as an industry, because this is one that Medicare is getting closer and closer to right. So Medicare does not require a prior authorization. The chair just needs to be on file. They do still require proof of continuous need. And And they still do have some codes that they think of as replacements that require a face-to-face encounter. But for the majority of CRT repairs, and recently, within a couple months, they removed some additional common repairs from the ACA list that required a face-to-face encounter. So we're seeing progress. We need to see that progress move to the Medicaids. We need to see that progress move to commercial payers to take away this ridiculous burden on the client of waiting 3, 4, 5 times as long because of the prior authorization process. And in this case, doubling the administrative cost to support a repair and increasing the cost within the industry. And so pretty simple, we're jumping straight to the recommendation that mostly aligns with what you see with Medicare today. So the first piece is just the equipment is on file. The equipment being repaired is either on file or proof of payer authorization is available within 5 years. Nothing else beyond that, not continuous need, not anything else. They were appropriately justified for CRT, right? A chair they're supposed to be in constantly for CRT. Justification on file, obviously, the supplier has detailed equipment and labor information on file with justification or reasons for repair of each item. And then finally, which we didn't talk about, again, something that Medicare has right, where appropriate, a temporary replacement should be covered. Today, the burden falls on the supplier to hopefully be able to afford to have an adequate loaner fleet that fits many folks appropriately and provide that free of charge for most payers, because people that get in this industry care about what they're doing. They care about the clients they serve. And so we're spending more money when someone's chair does not work and providing a free loaner to that person so that they can continue to get out of bed and live their life. Now, Medicare understands this, and they do have a benefit for temporary replacement while a repair is being conducted. We should be setting the expectation, a standard that other payers are following the same practice. And we can talk about, and we're going to talk about a little bit of the how we can accomplish these things, but that's the proposal and how we look at that. And then again, back to Gerry, if you want any additional comments on this, but the same look at why change, why is it important?
Yeah, I don't think we need to, that I think that slide, tells it all, and we pretty well covered the elements of that slide.
Yeah, and so the last slide before we go to Q&A is around, well, how do we do this, right? It's all pie in the sky. It sounds nice. It sounds like it would be easier. You've given some proof that when it is that way, it actually happens faster for the payers that do it that way. But why do we still live in this world that we live in, and what can we do as an approach? And so Gerry, you're highly involved for a long time in this industry, and appreciate your thoughts on this. And I have a couple I'll add in as well.
You know what I'd like to do? I think, Julie, if we could get somebody, the chat room is blowing up. It's crazy. So if somebody is really interested in jumping in with some questions or comments, if you could raise your hand, and then Julie will let you in. And I think also too, if everybody is interested, we can pull this chat as a PDF, and then Charles and I will look at this and drill it down into some concise answers for certain things, and see if we can meet some of the other questions. Because I'm imagining there's probably over 100, maybe 110 comments.
So I actually have filtered through comments versus questions versus conversation.
Okay.
So I'm just going to read aloud the question, and then I'll go back. If somebody has another question, again, I can't see hands popping up just because
sorry.
shared, but if you type your name in, I'll call it out. This one is from Diane's laptop, and her question was repairs for those who change insurance plans frequently, and who would be responsible. I'm guessing she means by the current model, but also potentially in our projected model of what might work better.
Yeah, the current payer that the client or patient is enrolled with is responsible for the repair. But again, there'll be different requirements on that, on how to get it on file or prove necessity, et cetera. And it differs dramatically by payer. And the proposal that we have would state that either they're on file with the existing payer providing the equipment, or we have proof of them being appropriately authorized for the chair from a different payer.
Thank you. To summarize for you both, especially Charles, who can't see the conversations happening, most people have seen increased denials over the last year. Some people have found success with great detail explaining the exact MRADLs that would need to be performed in the home to improve coverage, particularly I think for power tilt and recline. Justifications for the exact medical, like listing as how someone would die without the piece of equipment, which is my favorite flair to add to an element. There's a lot of debate between the narrative and the form template. If you are looking for a template, lots of people have shared their emails. Feel free to swap templates on your own time. For most folks, they've said that the template works best for them, typically in Word. There's some folks that have an Epic format. For me, I can copy and paste the Word one into Cerner if someone's using Cerner. Then there were some people discussing a standardized form. I guess back in the day, someone had suggested using that across the board so that payers were getting the same form, therapists using the same form. The discussion was that doesn't always meet all of the clients or the equipment that you're requesting, but I'm curious what you two would say about that. Do you think having a standardized form for CRT across the board for every payer, every prescriber, do you think that's a good idea? Do you think the industry should take that over and start to work on that? Yes or no?
Yeah. I mean, I have a strong opinion on that. I'm sure in some ways Gerry's differs than my opinion, and the folks in the room, many differ from the opinion. That's okay. We want to debate and brainstorm. From the angle that I look at it and how often we see deferrals and how often we don't see deferrals, but the paperwork goes back and forth to get it correct. I do believe an appropriate solution to that is some standardization on form. Now, I think what scares people when we say standardization means, well, you have no ability to add detailed information about the specific patient. No, that's not what I'm saying. But a form that helps you understand what needs to be justified, how it needs to be justified, and opportunity to add additional clarification on the justification makes it easier for folks. And I've been involved in implementing this in different places where therapists were really struggling with our ATPs, and in a situation they can't even manage to get it to go through to get an approval at all. And if they do, it's taking 180 days to get somebody a complex chair, to help train them on a format they can utilize to understand how they need to approach this. And all of a sudden, it's being done in 80 days instead of 180 days because of the conversation. I do think if we put our brain power together and worked as an industry and approached a software or something that we helped develop in concert with payers, therapists, ATPs, it could put us in a better place.
Hey, Charles, I would just say, our concept is standardized documentation. We're not sure what that form takes yet. And to go back to I know the one question that was in the chat was about the Houston form, and there was also one that was developed out of RIC that were really profoundly, to me, comprehensive and never got traction. And I don't know whether it was a fault of the form or a fault of us in the community, but that would be something to be considered. This is purely the first introduction into the concept of standardized documentation. If the template is part of the way to go, that'd be great. But we've watched that thing circle the drain for I can't tell you how long, and it just, in certain places, I'm sure it took off like wildfire, and other places it did not.
And that's where I was going to go. So in some places it did take off significantly and help folks significantly. Houston Methodist form has significant use and expands out in the environment today. In the Pacific Northwest, they're utilizing a new software called ACEs, which is an offshoot of a CRT system called Atlas. But are having extreme success. It's a very sophisticated LMN program. It's newer, but it's probably maybe the best one on the market. And I've seen the difference. It's cut down the paperwork time to a third and the deferral percentage a third. And so when I look at it from the perspective, I see the results when something sophisticated and good is implemented to help. And it is also faster to do for the therapist that's struggling with how much time they have in their day.
To show you how much debate there is in there, there's also a lot of stuff in the chat about what to call it. So it's specialty evaluation, LMN, LOJ, specialty. A lot of my very passionate friends are having quite a debate on or very strong feelings about how it should be termed. So that's also part of the mix. You know, what will it be at the end? So we're running near out of time.
So I think the last things to mention here, there is apparently another course, IC 83, about developing a standardized assessment today at 4:30, if people want to go over there. Just as a little advertisement for another course someone posted in here. A lot of people are talking about different requirements for forms based off of state Medicaids, etc. I think the only person who requested to state something is Lauren Rosen. So if you want to unmute, you can.
No, do not unmute Lauren Rosen. We do not have the time.
4 minutes.
No, just kidding.
Is the shortest amount of time anyone's ever given Lauren Rosen to speak. So go girl. Again, the chat will be saved as a PDF. We'll figure out how to get that posted for you too. Because there's a lot of great stuff and resources.
There really is.
If you want to unmute the
Zoom. So Gerry, you knew you couldn't make it through without me talking. Come on.
I know.
I always like to talk, but no, I just, the forms, have caused problems in the state of Florida. We implemented a form based on the RIC form, and it turned into an absolute nightmare. And those of us who actually do DME and complex rehab for a living all said, I can't do what I need to do. I can't give the information that I need to give. And the people who still didn't know what they were talking about with DME still couldn't do the form right. And so I think that's been the limitation to form development is that those of us who know this stuff don't like the forms. The group that is too new can't fill out the form. So it's still put the supplier into the middle of everything. And I think we need to come up with something, but I don't know if it's a true form, as you were saying, but just something that works for all of us.
It's not the intent. The form is an idea. And I think maybe, and I can only speak in my market, I think part of the reason that the forms were working well on the clinical level, we never got the funding sources buy-in. Yeah, so it's everybody has to agree to what it's going to look like at the end, I think is the key.
Yeah, and that's a difficult, much longer conversation, right? There's limitations on what can be done. There are luminary clinics and rehab hospitals and so on that have their own format that they utilize with their therapists, and they're integrated into that and trained on that and comfortable with that. And the reality is everybody uses a format. The question is there something that could be superior to what's currently being utilized? I think the answer is yes. With available technology and so on that exists. I think the last thing I'll say is, because I know we got to shut out here. When we think about how to work on changing these things, we've done a little bit of trying to take on the whole cow, right? And what we're starting to see is when we take smaller pieces, we're getting successes. When we told Medicare, the DPD 7-element order piece is confusing to everyone, overly complicated and causing a lot of back and forth, and just focused on the one thing. They changed it. Working in legislation right now with a House member to hopefully get the outside of the home piece taken care of by itself, to make prior authorization a requirement of payment, a guarantee of payment, instead of bait and switch on clients that it's authorized and then all of a sudden it doesn't get paid after delivery, biting off one piece. So that's one way to think about what we're doing is what are the pieces that we can take and have a little bit of success and make it a little bit better every day.
Excellent.
I appreciate the time.
I am going to interrupt both of you for 1 second just to state that the CEU code is NL4LHD, and it's also in the chat. It's towards the bottom of the chat, so that should be easy to find. Julie, the monitor for the session, also recommended continuing the discussion later in the CTF meet and greet if people are interested. And someone else had asked if you guys would be able to post the slides to the portal when you're finished so that they can see the
Yeah,
slides.
there was a little bit of a quirk. They will be there. They're
Perfect.
probably not today, but maybe tomorrow. I just don't have the time today. So
That's okay.
they will be there.
That's
And
great.
thank you all of my friends who showed up to support Charles and I. And
We're
those of you
120
that
people.
also aren't my
Yeah.
friends. But,
Yes, thank
and
you so
Charles,
much.
thank you. So
Thank you.
sharing.
Really enjoyed it. I appreciate it, everyone.
take care.
Thanks so
Charles, I'll
much,
talk
everybody.
to you another day.
Sounds good.